Welcome to the Dysphagia Matters podcast. I am Jule and with me is Julia.
Yes, hello. So for us, and maybe also for you, March is conference time. And for us, conferences are the best place to gather new ideas for topics and guest speakers and also record episodes for our podcast. But before you will hear from our new guests, we would like to share one very exciting speaker we met at ESSD last September.
This is Professor Heather Starmer. She's a clinical professor and the director of the Head and Neck Cancer Speech and Swallowing Rehabilitation Center at Stanford University, and she's an expert in FEES diagnostics. So in this episode, we explore topics like the sometimes overlooked aspects of the FEES preparation and how FEES and videofluoroscopy can complement each other rather than compete.
We also discuss common challenges in interpretation that many clinicians face, and Heather also reflects on emerging developments that might shape dysphagia assessment in the coming years.
So whether you're just beginning your journey with FEES or use it regularly in your clinical practice, we hope that this conversation provides some helpful insights for your work.
And don't forget to subscribe so you don't miss our upcoming episodes featuring the brilliant minds we met at this year's conferences. Welcome, Heather. We're really excited to have you with us today on this episode.
Thank you so much for the invitation. It's always a joy to have conversations with like-minded dysphagia experts, and so thanks for having me.
To bring everyone on the same page, could you give us a short introduction of what FEES is?
Absolutely. So FEES stands for a Flexible Endoscopic Evaluation of Swallowing. It is one of the instrumental swallowing evaluations that is considered to be gold standard for the assessment of pharyngeal dysphagia. So originally, the FEES examination was developed by Susan Langmore as she was working with the otolaryngologist and saw this tool as something that might be helpful to particularly focus on safety impairment of patients with swallowing impairment. So the examination involves passing a flexible endoscope from the nose into the pharynx, where the clinician is able to visualize the structures of the pharynx and the larynx and the relationship between the bolus and foodstuffs with the structures of the pharynx and larynx. And so it allows the clinician to evaluate physiologic function in the pharynx. It allows the clinician to look at safety impairment, meaning any issues with further liquid entering into the airway, as well as efficiency impairment, which is related to residue within the pharynx. So it's a really nice clinical tool that we can use as dysphagia specialists to really understand what's happening with our patient's swallow.
Yeah, wonderful. And you've already said that an endoscope is passed through the nose. So before actually passing the endoscope through the nose, what are the most critical preparation steps that we need to take?
Yeah, that's a really good question because I think it's important that we remember that all the things that we're doing leading up to the FEES are very important. And I would say, in my mind, probably one of the most important things that we do in preparation is to take a really good, thorough history. So really trying to understand exactly what the patient's symptoms are, what the trajectory of the issues have been. Is it something that was, long-standing and unchanged, or is it something that's rather acute or progressive in nature? And that history really helps us to develop some differential diagnoses before we put the scope in. So every time we're going in and into an instrumental, whether it's FEES or video fluoroscopy, we should go in with an idea about what we think we are going to see so that we are able to, focus our examination, plan our examination accordingly. So I think that clinical history is a really important part. And to go along with that, also, very thorough cranial nerve examination we want to be looking at, particularly because FEES doesn't look at the oral phase of swallowing. We want to make sure that we are paying particular attention to cranial nerve function. And then there's sort of the practicalities, right? So one of the things I always tell my students is, when you're going to be putting a scope in somebody's nose, it's not necessarily the most comfortable thing. Nobody really wants you to be there any longer than you need to be. So it's really important that we've got everything else prepared before we start the exam. So we need to make sure all of our food is set up and ready to go. We need to make sure our equipment is working properly. Sometimes we run into situations where the foot pedal that we press to record doesn't work. So we need to make sure that that's working so that we're not having to pull the scope out, put it back in. And then obviously patient prep is a really big part as well. So I think part of, even though this is not a surgical procedure, it's not as invasive, it is an invasive procedure. And so we need to make sure our patients really have given informed consent. They understand what we're going to be doing. They are, mentally and physically ready for the examination. And I know the physical prep can be different from site to site. So in some places, people are using topical anesthesia or decongestants. And you want to make sure if you're using those that you apply them early enough that they're actually effective. I oftentimes see some of my surgical colleagues spray a patient and then immediately put the scope in. And at that point, the spray is not done any good. So we want to make sure that we're giving whatever topicals we're using ample time to really be effective for our patients.
So some are using topical anesthesia and some aren't. Are there guidelines recommending either or maybe both, or it doesn't matter?
I think that it is very much a case by case. So there's been some work that's been done out of Susan Langmore's group looking at the effect of topical anesthesia on swallowing. And so we know that there is, too little doesn't really do enough, too much can impair the swallow. So there are some guidelines, and that varies depending on what the delivery system looks like. So some places use atomizers. They blow a lot of medication in, so it's a smaller amount. Other places use like hand pump. So you have to look at what system you're using and work with that. I know working in an inpatient setting, I never used topical. It wasn't easily available. There were barriers to getting it from the pharmacy, and most patients tolerate the exam absolutely fine without topical. Now I work in a cancer clinic outpatient practice where everybody else who scopes, so all of the surgeons, all of the medical oncologists, the radiotherapists, they all spray patients before they scope them. So the patients have an expectation that they will be sprayed before they are scoped. And so we always end up spraying patients unless they ask not to be sprayed because in this setting, that's sort of the expectation. So I think that there's a little bit of evidence. Most of the evidence that has been collected on topical was done for just flexible laryngoscopy, not specific to fees. So there's been some work where they've looked at, how much does it contribute to comfort? And there is a slight benefit. So patients are slightly more comfortable if they've had access to topicals. But it's not a huge difference. So I think in places where you're not using it, that's totally reasonable as well.
Yeah, and if you're not using too much, then it doesn't impact sensation.
Exactly. Yeah.
You've mentioned in your preparation that it's very important to think about what you want to find out, to check patient's history and what is the question. How does FEES help you to tailor the dysphagia management plan, or which role does it play in the evaluation of swallowing function?
Yeah, I think that depending on the site that you're in, I think there may be different roles for fees. So I think certainly a fees examination that's done by somebody who really understands the entire process can really tell us a lot about physiology. I've had conversations with colleagues that are much more fluoro focused, and traditionally everybody thought, well, you can see physiology so much better in fluoro than you can see with fees. But some of those individuals, as they started doing fees, said, oh, wait, you're right. You can actually see quite a lot. And so even though we don't necessarily see the events during the swallow, we can do certain strategies or maneuvers with patients before we even start them swallowing to learn a little bit about how well does the tongue base retract, to learn about how does the pharynx constrict, how are the vocal folds moving, how is the velopharyngeal closure pattern. So I do think that fees can tell us a lot about physiology. Oftentimes, one of the big questions that the referring providers are looking for us to answer is this patient safe to eat and what are they safe to eat? And I think we can answer those questions very, very effectively with fees because fees really gives us a good insight into the safety of somebody's swallow as well as the efficiency of their swallow. And so when that's sort of the number one question, I think fees is very well suited to answer that question. Certainly, fees can be very effective in looking at compensatory strategies as well. And, there are certain strategies that may be less easily visualized on fees, like Mendelssohn maneuver, for example. But I find there aren't that many people using Mendelssohn maneuver as a compensatory strategy. So when we're thinking about things that are more commonly used, like chin tucks and head turns and breath holds, fees is really lovely for being able to assess the efficacy of those strategies. So I think it can really give us a lot of information from the physiology of the swallow to looking at safety and efficiency parameters, and then also looking at strategies and are there things we can do to improve that patient's swallow and make it more effective.
Yeah, wonderful. And sometimes there's a discussion around, and you've already touched on this, around whether video fluoroscopy or FEES is kind of better, quote unquote. And oftentimes the argument then is more, it's not one is better than the other, but it's complementary. So what would you say, what are really the advantages of FEES, or where is it maybe better suited, and in which cases or situations might it not be suited as well as, for example, video fluoroscopy?
Sure. Yeah, that's the most important question, right? What test do we do with which patient when, right? And so I think there are different ways to think about it. So thinking about it from like a pragmatic perspective, one of the things that FEES offers is this really flexible delivery model, right? So if you have access to endoscopy, right? That's the key piece. If you have access to endoscopy, oftentimes it's the kind of thing that you can decide to do right in the moment. So a patient comes in, maybe they're coming in for a follow-up and they've been doing really well, and you plan to just basically see them, maybe do some exercises or do some education, but they come in and they have a new complaint that you weren't expecting or anticipating. If you've got fees available right there on the spot, you can look and try to evaluate what's happening for the patient. So I think there is that flexibility that is really lovely with fees that allows us to really offer an examination at any point at point of care. Whereas, at least in the US, I don't know anybody working who has super easy access to fluoroscopy. So usually the fluoroscopy suite has a limited number of slots each day. You may have to schedule it months in advance. So I'm seeing a patient tomorrow who has a history of esophageal cancer who is just not progressing with his oral intake. And I would much rather do video fluoroscopy with him because he has an esophageal issue, but I can't get him in for fluoroscopy for a month. And so fees will allow me to at least get a sense of, is there safety impairment? Is there efficiency impairment? Can I provide this patient with some recommendations to sort of push them off and get them started? So I think that's one of the really big advantages of fees is that flexibility and ability to offer that assessment in real time. But then thinking more about sort of the clinical pieces, I think one of the big advantages for FEES is that ability to directly visualize the anatomy. And so particularly for patients where there are both voice and swallowing issues, being able to visualize the larynx and see how the larynx is functioning is something that we cannot do that effectively on fluoroscopy. So it's definitely an advantage for FEES for those patients where there are both voice or airway and swallowing issues. We can also get a better sense of altered anatomy. So I work predominantly in a head and neck cancer setting. And so many of our patients have altered anatomy either because of the tumor, because of surgical resection where parts have been resected, or because of edema that's caused by either surgery or radiation. And those things are not always as easy to understand and visualize on fluoroscopy. So if I have a patient with altered anatomy, FEES is definitely going to give me that sort of 360-degree view in three dimensions of exactly what's happening, exactly how that anatomy is interacting with the bolus. So that's another big advantage. And then another piece is the ability to look at strategies. So again, with video fluoroscopy, I think you are equally able to assess the efficacy of a strategy, but I think being able to visualize exactly what that strategy is doing to the anatomy, to the angulation of the pharynx, to where the bolus is flowing through the pharynx, I think FEES gives us a slightly better look at that. And that can be particularly helpful for educating our patients. So if we want somebody to do a head turn, it may be that they're only turning their head, you know, about halfway as much as we need them to. So we can show them with the fees how the extent of that head turn is important for achieving the intended goals. So that sort of biofeedback that we can use with our patients, I think, is also a really nice advantage. And then clearly from a disadvantage perspective, I think, the literature is very clear. There are certain areas that we don't see as well, right? So we don't see the oral cavity. So we're doing some inferencing about the oral cavity. Our assessment of oral cavity is much more about our cranial nerve exam and our clinical evaluation, but we don't see exactly what's happening in the oral cavity during the swallow. We also don't see the upper esophageal sphincter. We don't see the esophagus. And so in those patients where we have concerns about esophageal function or cricopharyngeal function, we're not able to directly visualize that. And then the sort of during the swallow events. So at the point of whiteout, we miss a proportion of the activity that's happening then. So I think those are sort of the biggest things that we think about in terms of disadvantages. And then, one of the things I think it's important for us all to remember is that because so many of our patients have referred sensation from the esophagus to the pharynx, we have so many patients who are presenting with dysphagia symptoms that sound to be pharyngeal. And then we look at their pharyngeal swallow and we don't see anything wrong. And I think the danger with fees is assuming that we've seen everything we need to see. Whereas with fluoroscopy, if we do that esophageal sweep, we're able to at least get a snapshot of what's happening in the esophagus, even though it's not a formal esophageal assessment. So I think that's one of the other things that we need to just be really cautious about with fees is that we're not assuming that somebody is normal and that this is maybe a functional impairment when it may actually be an esophageal impairment.
Yeah, really good point. And I like that you said that if you do the esophageal sweep, which kind of means you can do it, but it doesn't always mean that actually clinicians are doing it. So you got to do it to get the whole picture.
Right, absolutely. Absolutely. I think that particularly those of us who are speech pathologists, or, I know there are many different listeners probably to your podcast. So we probably have ENTs and maybe neurologists and maybe dental people. There are a lot of different people who care for dysphagia. And so I think we all think about it slightly differently. But I think for those of us who sort of live and reside more in the oropharynx, we have to remember that esophagus because it is often the factor that ends up being uncovered as the underlying cause of the dysphagia.
So some of the advantages you just named were about what is possible during a FEES evaluation and how it's possible to individually look at what helps this patient, specific compensation strategies, for example. How can clinicians still standardize their FEES protocols within that flexibility to ensure maximum diagnostic accuracy and consistency?
It's a really good question. So I think we have to think about standardization as the place that we start from. And so I think standardization is absolutely critical. I think we have to be thinking about using a similar bolus protocol so that when we are trying to compare a patient across time points or across clinicians, and not even to get into, the question about research and being able to compare things. I think that we want to have at least a minimum data set and then sort of like our standard data set. And then there's the extra. And I think sometimes people, when we get into talking about standardization, everybody gets really set in like standard. You have to do it the exact same way every time. And I think you have a minimum data set that has to be done the same way every time or most every time. And then there's the extra. So the extra might be extra consistencies. So for example, our minimum data set when we're doing a FEES, we do a minimum of 6 thin liquid trials, 2 puree bolus trials, and 2 like cracker or cookie trials. But in a head and neck cancer clinic, many of our patients have dry mouth. And so when patients have dry mouth, something like a cracker or cookie can look really bad. And it may be more related to the dry mouth than to the pharyngeal driving forces, for example. So we will also give a moist solid so that we can see, okay, if we give them a moist solid, what does that look like compared to a dry solid? So it helps us to sort of tease out a little bit whether we're looking more at a dry mouth issue or more of a pharyngeal impairment issue. So I think it's okay to add to your basic examination. Similarly, when we think about compensatory strategies, we want to do that, right? That's an important part of the evaluation is identifying strategies that might help the patient. One of the things that we learned in looking at our own data as we developed Digest Fees was that at times we tend to be really quick to jump to strategies instead of waiting to see if something is consistent over a number of bolus trials. So let's say somebody had some penetration to the true vocal folds within liquids, a clinician might immediately have that patient try a supraglottic swallow or a breath hold or something like that. And if it only happened once, we never answer the question of, is this a problem or is this a one-time event? And so I think what I would advise, and that's something that we had to focus on in our own practice, was let's get through the standard bolus protocol first, then do the other things after. Now, there's a caveat to that, right? Because sometimes you have patients that are profoundly impaired, right? So if you have somebody who has aspirated 50% of the first two boluses, I wouldn't go on to give them six thin liquid boluses without making any adaptation, because that's not safe and appropriate. So I think we have to remember that we have our clinician thinking hats, and it's okay to say in the moment, for this patient, it is not safe or appropriate for me to continue on a standard protocol and I need to adapt. But we just don't want to do it too early. We don't want to be too reactive because then we might miss the true patterning. And I think that's one of the things that Digest has been so helpful for is thinking about sort of the overall pattern of swallowing and not sort of isolated events as being important. Because now that we're using Digest and we're looking at patterns, we can see how frequently a patient might have a single episode of penetration or aspiration that's not severe in nature. It's just a trace trickle and it doesn't happen in the rest of the study. So I think we want to give our patients the benefit of the doubt and let them sort of declare. So back to standardization. I think I just went off on a very large side note, but we do have some data to help guide us about what that bolus protocol should look like. So the Bijan's lab, as well as Katrina Steele's lab, have looked at how many bolus trials do you need to really get the saturation to make sure that you're getting those important events. And so it seems as though, from a thin liquid perspective, we need to be getting a minimum of about 5 to 6 bolus trials to really have a high sensitivity to pick up on aspiration events. So if we're only giving, let's say, 2 or 3 thin liquid bolus trials, we may not be getting enough saturation to really see an impairment that may exist. As I said earlier, if somebody aspirates on those first 2 or 3, we've given them the opportunity, right? We have been able to uncover that impairment. But I think we don't want to underdose and miss important events. So I think using the data that we have is really helpful. Like I said, a minimum of 6 thin liquid boluses. If you're using a thick liquid bolus, I think the data is a minimum of 4, and then a couple of puree, a couple of solid boluses. Other things that we might think about from a standardization perspective, aside from the bolus protocol, would be what we're using to make it visible. So I know there's been a lot of work in the past, probably 5 to 10 years, looking at, is blue dye better? Is white dye better? Is milk better? Is barium better? And so I think thinking about how we're using contrast is another important way to standardize, because if I'm only using blue food coloring with my exam, but my colleague in my same clinic is using white, we might be seeing things slightly differently because of the differences in how that contrast works. So we want to make sure that we're getting pretty similar contrast enhancement across the different types of boluses. We want to make sure that, our patients are prepared in a similar way. And then I think the other piece that we want to make sure is that we are doing those sort of pre-swallow maneuvers to look at physiology. So, when you're in the nasopharynx, having the patient do something like ka 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 or pa pa pa, something that's going to give us a sense of velar elevation, having them sustain an S so we can get a sense of sustained velopharyngeal closure against pressure, having them do things like velar plosive words that like kitty kitty or candy or something like that, where we can look at tongue-based retraction, having them do something like a effortful siren to look at pharyngeal contraction, sniff maneuvers and phonation to look at vocal fold mobility. So making sure that we're doing all of those physiologic tasks before we do our swallow study, and then using standardized, reliable, validated measures in the same way across patients. So in our practice, what that looks like is we do a secretion scale of some sort. we tend to use the Murray scale, but depending on your population, you might choose something like the New Zealand scale that may give you more information for your population, but something that captures secretions, because that's one of the other advantages of fees over fluoro is before we even give somebody a bolus, we can see how they're swallowing, how they're managing secretions. So I think using a secretion score every time is important. In a head and neck cancer practice, we also use the revised Patterson scale, because that gives us information about edema and how edema is affecting the structures. That may be less important in a stroke population or a Parkinson's population, but in a head and neck population, that might be a tool. We might use tools that individually assess safety and efficiency. So we might use the penetration aspiration scale score, maybe the Yale residue scale, or something like digest fees that gives us both safety and efficiency, or something like VACES, which gives us, even more granular data. So I think depending on the population that you work with, you're going to choose which of the validated tools are a good match for your population, and then use them consistently in every exam, because then that lets you really compare that patient across time, or even if it's different clinicians doing the exam, so that you can get a sense of, how they're progressing or declining.
What would be your rationale for using the PAS and the Yale separately to assess safety and efficiency, or, for example, the digest fees, which assesses both in one?
Yeah, I mean, I think that where I come from in my clinical practice, so again, I'm working predominantly with head and neck cancer patients. I think the digest gives me the most important information because it gives me the big picture. But there may be times where I want to have a little bit more granular data. And that might be like in a research setting, or maybe somebody's got really subtle changes, and maybe that big picture isn't going to tell the story as well. So I might want to have the bolus level information for certain situations. I think the majority of the time, I'm not looking for a bolus by bolus. I want to know the big picture. I want to know overall, how is this patient doing? So I would say digest is the majority of the time going to be the scale that's most meaningful for me if I'm thinking about safety and efficiency. But if I have somebody who is making, very small incremental changes, I might use that bolus level rating to see if I can capture change in a way that maybe a big picture measure would not.
By bolus level rating, you mean the VASES?
Either VASES or penetration aspiration scale. So PAS, as you know, right?
Yeah,
I'm sure
yeah.
you probably had a podcast about this topic, right?
Not yet, I think.
PAS. Oh, okay. Well, good idea for next year.
Yeah.
Um, the penetration aspiration scale was designed to be used at every single swallow. So if somebody swallows 3 times for a single bolus, you'd get 3 ratings. And most people don't use it in the way that it was developed. So most use PS, the worst score or the worst score for a particular viscosity. But you can actually get much more granular with the PAS and looking at either at the bolus level or at the swallow level if you want to get really granular. So it depends on how you use PAS, whether it would give you more or less information. I think if all you report is the worst across the entire study, that's less informative than your safety grade from digest. But if you actually had, a table, I've seen this in some notes, a table where somebody gives the PAS, the Yale residue scale for every single bolus trial, that gives you that more granular data. But also VASIS does that as well.
So in that fees protocol that you mentioned about the different numbers of swallows per consistency,
Mhm.
but I was just wondering with the different numbers per consistency, how do you explain, or do you have an idea why there's a different variation between different consistencies?
Oh, okay.
Like,
So like, why would you do 6 for thin liquids and
yeah.
4 for thick? Okay. It's a good question. In looking at the data that has been collected, these are sort of the numbers that have been highlighted as sort of the minimum number needed. And perhaps there's more variability and more need for more bolus trials with thin liquid because as clinicians, we tend to want to start small. Right. So a lot of times we're starting with either a teaspoon or a 3 cc or 5 cc bolus. And that is very, very different than handing somebody a cup and saying, go ahead and take a sip. So I think probably we are introducing some level of artifact in a sense that when we give really small boluses because we don't feel comfortable challenging the system from the get-go, that probably adds extra boluses that maybe if we just jumped right to a 10 or 20 ml bolus, maybe we wouldn't need all 6 bolus trials. That's probably the most logical thing that I can think of in terms of why we would need 6 thin versus 4 thicker is probably because of our comfort in giving bigger boluses.
Yeah, that's interesting that, or yeah, a good point that we also have to question ourselves in the whole process.
Right. Right. Absolutely. And, some people will start with 1 ml, some people will start with 3 ml, some people start with 5 ml. And I think sometimes it depends on the patient that you have in front of you as well, right? If I've got somebody with ALS who's had 3 aspiration pneumonias, I'm going to be more conservative with that person versus my 50-year-old head and neck cancer patient who had a TORS resection and has never had any pulmonary issues and is young and otherwise healthy. I'm going to feel much less conservative with that patient. So I think, some of it does come down to also the kinds of patients that we're working on and the acuity of their illness.
Okay. And let's imagine we are performing a FEES right now on a patient and we've had 6 or 7 swallows on thin liquid, and now we have this different outcomes or different impressions of the swallowing functions. How do you distinguish between the clinically significant and the minor swallowing variations?
It's a really good question. We just had our American Speech Language Hearing Association meeting last week, and there was a fabulous panel of speakers, which will be available on the American Board of Swallowing and Swallowing Disorders website relatively soon. It was the Swallowing Symposium, and it was talking about innovations in fluoroscopy. But I think the topic is also relevant to fees because one of the things that there's been a lot of research on in fluoroscopy recently, especially the really awesome work being done by Sonia Molfenter, is looking at normal. And there's such a huge variation in normal and fluoroscopy. And we have a lot more data about that range of normal in fluoroscopy than we do in fees. So we don't have a similar body of work to look at to help us understand what might be normal variation versus what might be impairment. So one of the things that I'm always thinking about is thinking back to that clinical history, right? So it goes back to the patient's concerns and hearing about their symptoms and what they're experiencing. So if a patient's symptoms are, choking all the way through the meal, and I see a little bit of bolus spills to the vallecula before the swallow, never goes further than the vallecula. Am I worried about that? Do I think that's a meaningful impairment? Probably not. Do I need to do a chin tuck for that person because they do have this sort of phase transition delay? Probably not, because it's not causing a problem and it's not relevant to their symptoms. So that's sort of the one of the big things that I'm constantly thinking about is this relevant either to them from a symptom perspective or to me from a concern about safety and efficiency? Because there is a wide range of normal in terms of when our swallow triggers, in terms of having a little bit of residue. And we know fees is more sensitive to picking up residue than videofluoroscopy. And so if we see a coating of blue, again, is it really meaningful? Is it contributing to the patient's symptoms? Is there enough residue or is it building up enough over time that I'm worried that it may then spill into the airway? So I think that really thinking about, how relevant is this to the patient's concerns and to my concerns. Obviously, if a patient is asensate and I see something that's concerning from a safety perspective, I'm not going to disregard it because it's not important to their symptoms, because it's important to what I'm looking at. So I think it's that sort of critical thinking of what does this really represent because we don't have as much data about the range of normal and a lot of the parameters we're looking at for fees.
So interesting. Because, like you said, we don't have enough data on what is normal, but then I think or feel oftentimes I myself don't know enough about normal. Maybe there's some data, but there's so much we need to learn. And oftentimes we start right away about what is actually not normal before looking at what is normal.
Yeah, absolutely. And I know there was a study, I think it was Alicia Vose and Inessa Humbert, that did a study a number of years ago where they showed an examination This again was fluoro, so we're extrapolating, but they showed an examination to a lot of different clinicians with different experience levels. And I think there was something like 14 different physiologic impairments that were picked out. And it was a normal person. It was not a disordered swallow. And so we have this bias, and we have to constantly remember that we have this bias that we're looking for problems, because that's sort of our job, is to be the sleuth and figure out what's going on with somebody's swallow. So we need to make sure that we're not over pathologizing things that are just, they're just findings. And that's one of the things that I really like about the digest framework, is that digest level one, whether you're talking about safety or efficiency, is acknowledging that there's something there that's not 100% perfectly normal, but it's not important enough that we need to do anything about. So those are those impairments where you're like, yeah, I could do a chin tuck, I could do a head turn, I could do a second swallow, but I don't really need to. And so I love that about that level one impairment from digest, is it's okay to say that it's not normal, but it's also okay to say it's not important.
So, what would you say are the most common pitfalls in fees interpretation? Maybe one might be what we've already touched on, kind of the confirmation bias. So, we're looking for something to be abnormal, and then, of course, we find it.
Right, right. Yeah, so obviously that, but that would apply to everything we do.
Yeah, that's
Whether we're
true.
talking about clinical exam, video fluoroscopy fees. Absolutely. I think one of the things with fees that we have to remember is that it can be a lot messier than video fluoroscopy. So anybody who's done fees knows you have time. It does not matter how good you are as an endoscopist. There are going to be times that the camera is going to end up coated with some food, or there's a mucus bubble that's getting in your way. And so there are visualization challenges, and we have to work pretty hard sometimes to get a good enough quality exam to answer what we need to answer. And sometimes we have to accept that I cannot get a good exam on this. I had a patient that I needed to take to fluoro this week because his swallow was so impaired that no matter what I did, I could not get good visualization of the airway in a timely manner. I did not feel confident, and he was coughing a bit, and I never saw anything in the airway, and that made me really uncomfortable. So I think we have to understand that there are inherent visualization challenges that can impact our interpretation. On the other hand, with fluoro, we have the issue of the fluoro gets turned off. So there are things that happen when the camera is off. So we looked at some of the simultaneous fees and fluoro data that Jessica Pesena had collected in her work with Susan Langmore. And it was really interesting because watching simultaneous fluoro and fees let us see that both of them have limitations. So we're really quick to point out the limitations of the other tests. Both of them have limitations. One of the other areas I think we have to be really mindful about is that seeing that posterior trachea is really challenging. So if you've got somebody who's got trace aspiration that's coming from the interarytenoid space, it's really hard to see what's happening in the immediate subglottic area. So that is an area that we have to, again, be really careful about making sure that we're not underrating in that case. Another thing that we have to think about is, particularly in the context of either vases or digests, where there are some rating rules around when you rate residue, is that it can be hard to establish sometimes what is the primary swallow versus a clearing swallow, right? Sometimes patients are piecemealing it, and we can't see in the oral cavity, so we don't really know what's the big bolus versus, maybe a preliminary bolus. So that can be a little bit challenging, and we have to again sort of put on the critical thinking cap. And then I think the other big thing is that issue around the anatomic variations. So fees is really easy in a patient with normal anatomy, but once you start having edema where, let's say, the piriform sinuses are obliterated because the arytenoids are so edematous, or you've got part of the epiglottis that's been resected, and so your visualization is challenging, that's when fees can become more challenging from an interpretation perspective, especially with some of the scales that we use. So, for example, the Yale residue scale, the Brax residue scale are both looking at residue in terms of what percentage of a space that's filled. And if that space is not normal because of edema, because of structural changes, how do you use that scale? Is it valid to use that scale? And that's part of the reason that we didn't end up using that same terminology for digest, because in the head neck cancer population, anatomically, so often I would question the validity of using a Yale or a Brax because the spaces are not equivalent to what we would normally see. So I think those would be some of the pitfalls that I think about predominantly with fees interpretation, other than like we talked about earlier in terms of our own biases and keeping those things in mind.
Thank you for giving us this detailed picture of the current state and the advantages and disadvantages and how we perform this evaluation. Since everything is emerging and evolving, what are the innovations in FEES technology or application at the moment?
Yeah, so I think that what we've seen in the past, let's say 5 years, there's been a lot of interest in scale and scale development. So with both Digest and VASES both being published about the same time, I think we've recognized as FEES clinicians that we need tools that are comparable and allow us to provide the most reliable examination. Any of both video fluoroscopies and FEES, they're clinician interpretations. And so we can never get a truly objective measure. There's always subjectivity because it's all through the eyes of a person. But in using scales that are validated and reliable, we can get closer to that state. So I think that that's where we've seen a lot of work being done in scale development, which I think is really exciting. I think, for many years, we all just kind of described what we saw. And so now we have some scales that allow us to be a lot more objective in what we're looking at. I think there's some really interesting work being done in using other technologies to better quantify things. So, as I mentioned, when we're looking down with the fees and we're looking at the vallecula or the piriform sinuses, we are estimating what we think the depth or the size of those areas are, but we really don't have any way to measure that. We don't really have any way to measure how much residue is really there. And so I think that there are some researchers that are looking at other ways to maybe do some of those measurements. So I know Jackie Allen in New Zealand, for example, is doing some really interesting work to try to use available technology to measure things better. And it makes perfect sense. They're doing it in other industries. This technology exists. We just haven't figured out how to use it in the human body. So I think that those are really exciting areas. And then I think there are a lot of people that are starting to think about machine learning and AI and the role of machine learning and AI in any of our instrumental evaluations. And I would say at this stage, things are a little bit more in their infancy for fees. I think there's been more work done in fluoroscopy than in fees. But certainly, could we use machine learning algorithm to help us identify key events like aspiration, penetration? I'm sure we'll get there. We're just not there yet. So I think that's going to be another space that we're going to see a lot of really interesting work going on in the next, 10, 20 years.
And what other future research directions do you see, or what would be a topic that you would be very interested in, or saying someone should do this?
Yeah, yeah. I mean, I think the AI thing is definitely an area of interest, and I think most of the work in fees and AI that's been done has been done in Japan, to my knowledge, and I think maybe there's some work that's been done in Switzerland as well. And so what they've seen so far is that AI is not been that great. It's not been that much better than clinicians in picking up key events. So we've got to figure out a better way to train the machine to identify these events. So I think that's certainly an area. And I think about it particularly in the application of providing care in either developing countries or areas where things are not as well resourced. So I always say, I acknowledge I work in an ivory tower, right? Stanford is an institution that is very forward thinking. We have access to technologies, we have access to things, but I recognize that many, many and most clinicians don't have the resources that I have available. And so trying to think about how can we leverage these tools to be able to impact patients and individuals in areas where they don't have access to that. Could there be some way that we can do remote fees where we have, a trained clinician who can put the scope in, administer bolus trials, but maybe they don't have the expertise to do the interpretation. And then could that be somehow remotely viewed by another clinician? I mean, if they're doing remote surgery in the battlefield, why can't we somehow use technology like that? Obviously, there are inherent challenges in trying to bring technology into less resourced areas where maybe they don't have access to high-speed internet and things like that. But I think that when we're thinking about sort of future advances, that's one of the areas that I'm really thinking about more and more lately is how can we improve the equity of care and making sure that as we're developing advances, we're using it for the folks who need it the most, not the centers where you have every technology available to you and every resource available to you, but how can we use technology to help those that don't have that? So I think that hopefully we'll see some of those things sort of coming up in the near future.
Yeah, I think that's very interesting also to change that point of view instead of going fancier and fancier all the time with all different technologies. But what's the use if people cannot apply it or don't have the access to it? Yeah,
Right.
great.
Right,
Thank you.
absolutely. Yeah, we keep going more and more technical with our endoscopes, but you know, can we improve the lower level endoscopes for people who can't buy a $15,000 endoscope? We probably should be thinking about that.
Wonderful. Thank you so much, Heather, for taking the time, for getting up so early, and for sharing your invaluable expertise and knowledge with us and our listeners today. Thank you.
Oh, it's been a real pleasure. Thank you again.
Thanks so much for listening. If you enjoyed this episode, leave a review wherever you listen to podcasts. You can connect with us on Instagram, LinkedIn, and Blue Sky, or visit our website, dysphagiamatters.org. We'd love to hear from you. Until next time, take care.